はい、皆さん時間になりましたので、今月の勉強会を始めたいというふうに思います。今日はですね、今週からシエラレオネ共和国から研修員の方が8名看護師がいらっしゃっています、研修に。で、せっかくの機会なので、シエラレオネの、ヘルスの状況ということで、今回はマラリアというところで、トピックスを選んでいただいてプレゼンテーションしていただきます。本日のプレゼンテーションは全部英語で行うので通訳はありませんが、またYouTube でまた後ほどアップさせていただきますので、それでゆっくり見ていただければいいかなというふうに思います。で、質問に関してはまたチャットボックスに別にこれ英語でなくていいので日本語で書いていただいたらまた最後に質問していただこうというふうに思います。So I introduce our presenter, and we have 4 presenters, right? And if they have a question, they are going to write the question in the chat box. And after the presentation, we have a Q&A. All right? Okay, so please present.
Thank you. Good evening, all. My name is Salima Tutamara from Sierra Leone. 4 of us are going to present on this topic today. The topic is malaria in children, Sierra Leone. Order of the presentation. Overview of malaria in Sierra Leone. Topics: types and causes of malaria, clinical manifestation and diagnosis of malaria, treatment and nursing management of malaria, prevention strategies and vaccination of malaria, then the challenges and further directions of malaria. According to WHO, malaria is a serious global health problem in Africa. It accounts for 610,000 deaths per year. 90% of these deaths occur in Africa. Then 438,000 deaths of 438,000 child die of this malaria in Africa. So due to that, WHO recommended a malaria vaccine for children to prevent them from malaria. Malaria remains one of the leading causes of illness and death among children worldwide, particularly in sub-Saharan Africa. Approximately 263 million malaria cases and 597,000 malaria deaths globally. The WHO Africa region accounted for about 95% of all malaria deaths worldwide. Children under 5 years remain the most vulnerable group, contributing approximately 76% of malaria deaths in Africa. The overview of malaria in Sierra Leone. Sierra Leone is a West Africa country with a tropical climate favorable for mosquito breeding. Population is about 8 to 9 million people living in Sierra Leone. Malaria remains one of the leading public health problems in our country. Transmission occurs throughout the year because 1, we have heavy rainfall. Then secondly, we have high immunity. And thirdly, we have poor drainage system. Because of the poor drainage system, there is always the presence of stagnant water, which serve as a breeding for mosquitoes. The burden of malaria in Sierra Leone. Malaria contributes to hospital admission and child mortality. Over 1 million malaria-related hospital visits occur annually. Malaria prevalence reduced from about 40% in 2016 to 22% in 2021. Economic productivity and school attendance are affected due to this malaria. According to this graph, this map, it shows the districts in Sierra Leone, our districts we have in Sierra Leone. This red map indicates the highest range of malaria. The districts that carry the highest range of malaria, which accounts for 59% of malaria, which is the Kwainadugu district, Bombali, and Tonkolili. Then we have the orange, which accounts for 50%, which is the Pujeon, Tonkolili, and Kambia districts. Then as well as we have the gold, which accounts for 40%, which we have the Moyamba, Bo, Kono, and Bombali. Then also we have the yellow, which is the Bond and Western area urban. What is this malaria we have been talking about? Malaria is a life-threatening disease caused by Plasmodium parasites. It spread through the bite of an infected female Anopheles mosquito. These parasites include, we have the Plasmodium falciparum, and we have the Plasmodium falciparum, which is the most common dangerous type that we have in Sierra Leone. And then the Plasmodium has type. We have the falciparum, we have the vivax, we have the malaise, the ovales, and the novelase. But from these 5 that I've listed, the falciparum and the novelase are the most deadly one if not treated quickly. The ovale and the malaise are moderates. Why children are vulnerable to malaria? Why children are vulnerable to malaria is because the malaria Plasmodium parasite in children under 5 years is much more higher than in higher group. This means the children under 5 years of age have low immunity against malaria. From the graph, you can see children under 5 years of age, they have low immunity for malaria, while children from 6 years and above, they have already been developed immunity for malaria. My colleague will continue from here. Thank you.
Good evening, all. Anesthe, I will continue with the presentation. Okay. I will start with the classification of malaria. Malaria can be diagnosed into 3 parts. The first one, we have the uncomplicated malaria, which is less severe. And then we have the complicated or severe malaria, as signifies the name. And then 3, we have cerebral malaria, which affects the brain. Severe malaria leads to coma, convulsion, respiratory distress, and death. These are the clinical signs of malaria, as you can see in the board. There is fever and chills, generalized body pain and ache, vomiting and fatigue, severe anemia. This severe anemia is caused due to the destruction of the red blood cells. And then we have convulsion. Convulsion is caused by high fever. When the children come in, they have been observed with high fever, that is 38 degrees centigrade and 100.4 degrees Fahrenheit. And this can cause fever and even convulsion on the children. We also have hypoglycemia. Because of the multiplication of the parasite, this parasite tends to consume all the glucose, and also poor formation of glucose from the liver. And also, there is poor intake of oral fluid due to vomiting from the child. Another signs and symptoms is failure, organ failure, and coma in severe cases. How can we diagnose malaria? Commonly in our settings, we diagnose malaria with a rapid diagnostic test, as you can see in the picture. And then we also confirm malaria parasites by using microscopic things in the blood. This is being done because after you have taken the rapid test, still this child continues with fever. So you have to do further investigation by doing the microscopic things in the blood. Clinical diagnosis. This is being done in the settings where there is no. This is being done where there is no rapid kit test and no laboratory. You can look at the child clinically, you can see the signs of malaria by looking at the conjunctivals. They sometimes look pale, and then touching the body, the child will be felt with fever. Case definition. Fever includes fever with malaria related to symptoms in the epidemic areas. For oral treatment, that is the uncomplicated malaria, we use tabs artemisinin-based combination therapy. ACT is the first line treatment. And then tabs antimeter lumefantrine is commonly used for children. And then paracetamol is used to reduce fever and pain. This treatment is also based on the body weight and the national guidelines. How do we manage severe malaria? Severe malaria can be managed with injectables. We have the first line treatment, which is the injection artesunate, which is being administered intravenously at 0, 12, and 24 hours, and then commenced daily. And if the child can tolerate orals, we continue with our oral medication. This medication is being given according to the body weight. If the child is less than 20 kg, we give 2.4 milligram per kg. If the child is above 20 milligram per kg, we give 3.0 milligram per kg. And then we also have a injection ketrazole. This one is being used to treat convulsions, especially where there is bacteria. And the protocol for this treatment is 20 milligram per kg once daily. If this child comes with convulsion because of the high fever, we give diazepam 0.5 milligram per kg rectally or intravenously. We did this 3 times, and if still the fever continues and the convulsion continues, we give injection phenibarbital 15 milligram administered slowly 15 to 20 minutes as loading dose. And then if still this child continues to convulse, we then continue with the maintenance rate of phenibarbital 3 to 5 milligram per kg. Nursing considerations. As a nurse, we have to monitor this child regularly. 1, we monitor the vital signs. We assess the level of consciousness using an appropriate coma scale. That is the AVPU. That is, you check if the child is alert, respond to voice, pain, and unconscious. We monitor the blood sugar level and treat hypoglycemia promptly. That is, we usually monitor the blood sugar 30 minutes or hourly. We maintain fluid balance and prevent dehydration. And we sometimes caution if this child is suffering from severe acute malnutrition, we don't give IV fluids. 2, we observe for recurrent convulsions. If there are recurrent convulsions, we open a seizure chart and then we document. We monitor oxygen saturation and provide oxygen therapy if needed. Sometimes this child may be on oxygen, but still the O2 is below 90, so we have to add CPAP. All this is being done by doing our documentation and then continuous monitoring of the patient. Thank you. My colleague will continue for me.
Good evening, everyone. I'm Khadija Jallo, so I'll take up from here. So we want to talk about the supportive treatment for malaria As you have seen from the previous slides, you'll notice that when a child have malaria, they are going to get hypoglycemia, they are going to have convulsion, that is from this slides she was talking about, and then they are going to have, like, we need to monitor fluid balance chart and everything. So you need to give the child supportive care, meaning not just to treat the disease directly by giving the antimeter or the artesunate. So if there is a convulsion, we need to arrest it. First of all, they most of the time have fever because of the disease condition. So anywhere there is a disease process, you know, there is going to be a high fever. And because they are having that, they are going to lose consciousness. So they get cerebral malaria. That is, if it is untreated, that is complicated malaria. So they end up having convulsions. So you need to give them oxygen if they have convulsions. And then you see, they talk about the phenobarbital and the diazepam, you need to give them. But before you give that, you make sure you have really checked the patients, and then they are really having convulsion by using the AVPU that she talks about, where you want to know if they are alert, if the patient is responding to voice, to pain, or they are totally unconscious, and then the glucose scale. Why do you want to do this for the patient? The rationale is there because everything we do in nursing, you have to have a reason. You don't just want to do it. So the indication for that is early detection of deterioration. You will know that whether the baby or the child is going to have a cerebral malaria, and then you treat immediately, or whether they are going to get shock or respiratory distress. So if you don't follow up on these ones, before you know it, they are already having convulsion, which you don't want to get, because we don't want the brain to have issues or the brain to fail. So you attend to them faster. So you want to prevent the management of hypoglycemia, meaning their sugar level is going to go down, because these babies, most of the time, they don't eat. Maybe they are having vomiting, they are losing their fluid, and then they are going to have hypoglycemia. So you want to check their blood sugar level. These are all parts of the supportive treatment to malaria, not just to give the anti-malaria. So you treat the basic causes. So you have to check for the blood glucose early, and then you check for the unconsciousness too, because if you know if your blood sugar is down, you're obviously going to have unconsciousness, and you don't want that. So why do you want to check that also? Malaria increases the glucose consumption and may cause hypoglycemia, which can lead to seizure and coma and eventually death. You don't want that. So you address first the blood sugar. Then you want to maintain hydration. As you say, if you have a very high fever, of course, you are going to lose some fluid. So you assess the fluid status, monitor intake and output of the patient. Because when they have this high fever, most of the time, they're going to produce like little amount of fluid, meaning they are not urinating well, the kidneys don't work properly. So, but whenever you check their hydration status, or you are monitoring how many times they have taken water, or you have given them this type of IV fluid, and how many urine they are taking out or vomitors, so you'll be able to know to do that. So preventing hydration while reducing the risks of pulmonary edema and fluid overload. So as much as we want to manage their dehydration or hydration status, maybe you have looked at the baby, because most times they have dry lips because of the high fever they are having and the disease process. So as much as you want to give, like, oh, this baby is not urinating, or their fluid level is down, let's give IV fluid, you make sure also you are evaluating well, so you don't overload them, because we don't want to have pulmonary edema also, or overfluid or overload of fluid. So you make sure you are checking that. And then providing oxygen therapy when indicated. So if you administer oxygen to patients when they have respiratory distress or severe anemia because of the breakdown of the red blood cell when the disease process is happening, because that's what the falciparum also do. They will have shock and then oxygen saturation below recommended level. Why you want to give them oxygen, you provide tissue oxygenation and then prevent hypoxia. So you make sure you are checking that also. Okay. Should continue? All right. So managing fever, I've talked about it earlier. You want to reduce convulsion and of course dehydration for the fever, and then you control the convulsion too. You observe for seizures, activity, administer anticonvulsants. As she said earlier, you start with diazepam depending on the patient, because if you are dealing with certain ages, you know whether you have to give them diazepam or you have to go directly to phenobarbital. But we start with diazepam first. So if no improvement, and then we go to phenobarbital. So you arrest that to prevent brain injury and complication associated with prolonged seizures. You monitor for severe anemia. As we said earlier, the falciparum make sure that the blood level in the system, it breaks it down faster. So you become anemic because of this condition. So you assess for pallor. You either take the mother's hand, maybe if you don't have the cue yet, they immediately like you want to do an HB, you want to check. Maybe at that moment you don't have the instrument to do that, or the laboratory is not available because these things happen. You can just put the child's palm and then the mother. That's what we do sometimes whilst we are waiting. So clinically, you know whether this patient is pale or not. And then fatigue, tachycardia, you know, if you don't have enough blood and you're having fever, you definitely have tachycardia. And then you monitor the hemoglobin level. You want to prepare earlier. You don't want to wait, like, oh, we need to wait. Later we'll check for the HB. No, the hemoglobin, you will not know if you don't check earlier, because you want to prevent the baby from suffering from anemia. So if you know earlier, severe malaria commonly causes the hemolysis. But whenever you know that this baby is having a HB level of 5, so you now inform the blood bank, because it's not like you, they have taken us to Red Cross. We have seen you have a system where blood is always available. For our own is different. So if I know now that I have a HB of 5, that's the time they will start calling relative, or the hospital will not have blood. They need to call another hospital. So it creates delays. So you need to monitor that earlier. Nutritional support, you encourage oral feeding when tolerated, or provide enteral support if necessary. So if they are not taking oral feeds, you make sure you prepare for enteral feeding, because you want to also prevent malnutrition. As you know, we have so many cases of that. You don't want to add to the number. So you support recovery by preventing malnutrition. So you educate caregivers also. You teach them how to handle medication adherence, because sometimes when you have them again, you have treat them and then you send them home, say, go and continue with this medication. No sooner they see the child is playing and everything, they stop. And by the time they are coming back, they will get the complication, the complicated malaria, and then they will have cerebral malaria, encephalopathy, everything will come in. You don't want that kind of complication. So you educate them, you encourage them to adhere to the medication, let them take it on time and everything, and then how to control the mosquito by coming into your house, whether you have to close your window early or you give them mosquito treated net, something like that, but you tell them like earlier, you educate the caregiver. So we have also the insecticide treated nets. For Sierra Leone, they will say they will give everybody, but because of the burden, sometimes we do prioritize certain individuals, which is the under 5 people, like the children that are under 5, and then the pregnant women. These people, we do prioritize them. So if we have like 5,000 mosquito bed net, we say, no, you distribute first to this targeted individual, then later you can give the other population. So we also give them that as a sign of preventive measures. So indoor residual spray, not everybody have access to this. So some people that really have money, I will not say rich, you can call them and then they can treat your house or something, like we have in this kind of thing. So they will spray your home like a paint. I will not say it's a paint, but it's like something like a paint, and then they will spray your room. So whenever a mosquito hits the wall, and then they are going to die. So some people have access to it. And then environmental management, eliminating mosquito breed sites by draining stagnant waters. Although it's difficult, but we do communicate, or we do advocacy that we should not leave stagnant waters around. You should clean your home. But most time we don't have access to water like everywhere you go in your country. Maybe you can just open the tap and so. So for us, because we don't have enough water in certain communities, if I have to launder my clothes, I don't throw away the water. I have to put it at least to do some other domestic work with it, because having water is not easy, but we still advise them. So because of this water, the mosquito is going to breathe there, is going to do this. So some people take the advice. So that's the reason we do advise them about the environment. So the seasonal malaria, we have what we call chemo preventive measures. meaning you don't have to wait until somebody have malaria before you treat them. You do like a public health treatment, like I come to the community, or like we are here now, we are talking about malaria. Say you don't need to put stagnant waters, we don't need to do this, or we give them like medication ahead, like a prophylaxis. For the pregnant women, like after their first trimester, they give them medication in the clinic, the antenatal clinic. They want to prevent mother and child from having malaria. So that is the chemopreventive monthly administration of anti-malaria drugs, doing malaria transmission season, because whole year, like it's always there. Like malaria is part of us now. So children aged 3 to 59 months is eligible to have this kind of treatment. So for the pregnant women, they give them SP Fancida. That's the sulfadiazine. That's what they give the pregnant women after their first trimester to prevent the child from having malaria. So intermittent preventive treatment in pregnancy, the administration of the Fancida, like I've said, for pregnant women, health education, educating community about malaria prevention, early diagnosis, that you should go to the hospital, check whether you have malaria, and then they will give you the medication. The medications are free. They are there just that people don't want to take, or they don't want to go for early treatment. So you seek early treatment, then you are safe. Community awareness, use of media, school, community, meetings, healthcare workers. These are all ways we do to prevent or support the preventive measures for malaria. So why was this SMC not widely implemented in Sierra Leone, like making it preventive, or like giving these medications to our people? It takes long time before it was implemented. Unlike many neighboring countries, these shells countries are like the Mali, the Senegals, the Gambia. They are the ones we call the shells country, where malaria transmission is seasonal. SMC is widely used in Sierra Leone. Experiences year-round malaria transmission is always there 24/7. So if you want to go to Sierra Leone, you take prophylaxis so you don't get malaria. So for this season, Sierra Leone historically adopted intermittent preventive treatment in infants, which is the IPTE, now called the perinatal malaria chemopreventive, as recommended by WHO. However, emerging evidence continue to inform malaria preventive strategies across the region. So this is a sample of healthcare workers donating the mosquito-treated net. So they have certain medication in it. So before they give it to you, they will ask you to like hang it outside for certain hours before you start using it. So you put it in your home and then you sleep under it, but they will prioritize under 5 and pregnant women. So more than 5 million treated bed nets were distributed between 2023 and 2024. So this 2026 also, April, we donated over like 5 million treated nets. So because I'm also a member of Rotary, so we went to community enhanced with the government. Yeah, we choose like a particular community that they are more vulnerable. Those ones that are living by the sea, you know. I will not say they are poor, but these are people that cannot provide for themselves. So we look for this vulnerable community, and then we distribute the mosquito net to them, and then inform them about it. So a campaign targeted approximately 9% of household combined insecticide insect nets increasingly being used. So people are now aware of malaria. They try to use it, because most people will say, whenever I use the insecticide malaria treated net, like I have itches, my body swell, or my this. Some people react to it because it already have medication. So if you don't take the precaution where they will ask you to put it outside for like 3-4 hours before you use it, obviously you are going to react to the medication that is in the mosquito treated net. So sleeping under the mosquito treated net reduce malaria transmission, obviously, because if the malaria hits the net, it's going to die, then it has no access going in there.
Konnichiwa, everyone. I am Beatrice Millicent Mina. I'm here to, continue where my colleagues stopped. And I'm going to talk about another form of preventive measure, which is the malaria vaccination. As we all know, prevention is better than cure, right? So we are trying to reduce the transmission of malaria among the people of Sierra Leone, especially for the children under 5 and pregnant women. So Sierra Leone launched this RTS, which is the repeat T-cell epitope surface antigen. We launched it on the 25th of April, 2024, and more than 550,000 were procured by the UNICEF with support from Gavi. Sierra Leone became one of the first countries in West Africa to introduce this vaccine into routine immunization services. Early implementation reports indicate high acceptance and successful national rollout. As my colleague stated earlier, we live with malaria. Malaria is like part of us. So when this vaccine was introduced, everyone was happy to receive it because we don't want to go through the complicated malaria and then the cerebral malaria and all that. So there was a successful nationwide rollout. Sierra Leone achieved approximately 90% readiness before introduction. That means sensitization went out before the vaccine came. So everyone was prepared for it. Everybody was eager to receive it. So when the time came, there was a large turnout. And initial vaccination coverage trends were encouraging, although uptake of later doses remains a challenge. This is where we have one of our problems. This vaccine comes in 4 doses. Usually, people are excited to take the first, second, but by the time they tell them to come for the 3rd and 4th, many of them are too lazy to do that. So there was a downfall of people taking the 3rd and the 4th doses. Long-term impact data on malaria morbidity and mortality are still being evaluated. Since it came out in 2024, we are still having our data to see how much it has improved. How this vaccine works. Studies show significant reduction in malaria burden. This vaccine reduced overall malaria cases by 39%. Can you imagine that? And for the severe malaria, it's by 31.5%. These figures are so significant for us because we know the amount of deaths that occur through malaria yearly among Sierra Leoneans. Reduce malaria hospitalizations and need for blood transfusions. As stated earlier by my colleagues, this infection or infestation affects the red blood cells. It breaks them down, so they do not produce as they should. So severe anemia is part of the complications of this disease. So when this vaccine enters into the bloodstreams, it helps boost up the red blood cells. So there is no cases of blood transfusion when this vaccine is present in the body. Most effective when combined with insecticide-treated nets and other malaria control measures. As we all know, you can't take the vaccine and then expose yourself to things or environments that will cause reinfection. So when you have taken the vaccine and you sleep under insecticide-treated nets, because we live in an endemic area, there are stagnant waters everywhere. We have poor drainage systems. So the mosquitoes are like our neighbors. So they are all around. So if we need to reduce the infection, the reinfection, there is a sensitization going forward that we have to sleep under the insecticide-treated nets and other control measures. The final phase 3 trials results reported by the WHO showed that the 4-dose RTCS/AS01 vaccine schedule reduced severe malaria by 31.5% among children aged 5 to 17 months. These are the targeted groups. These are the people that are more vulnerable to this disease. These are the people that, you know, when they are infected, by the time you said, if left untreated, they will enter into complicated malaria, convulsion, coma, and then eventually death. This was the day the government of Sierra Leone, through the Ministry of Health and Sanitation and their partners, they went to, receive the first malaria vaccine into the country. International partnerships. Key partners include WHO, UNICEF, Global Fund, the United States President's Malaria Initiative. Partners support vaccination, malaria vaccination, the training and bed net distribution. Sierra Leone, I would say, is developing, and we don't have funds to bring in those vaccines into the country. So this set of people are partners when it comes to malaria. Technical and financial support strengthening malaria programs. Sustained collaboration is important for malaria control. We need this collaboration with partners. We can put in the work, but we don't have the funds. So we need partners to help us sustain this particular, project. The challenges in malaria control, drug shortages and limited healthcare access. Like I said, we have about 9 million Sierra Leoneans scattered across 160 chiefdoms. And most of those people in those chiefdoms don't have access directly to their healthcare facilities because of where they reside. So there is limited healthcare access. The drugs are not enough to meet this particular groups. So this is one of our challenges. Delayed referral of severe malaria cases. Like I stated earlier, there are certain delays. Like, first of all, the people have to come to the realization that they have malaria and they need to visit a hospital. Because of our traditions and customs, many resort to herbal solutions. But by the time many of them come to say, oh, this herbal drug is not working, let me go to the hospital, it has become a severe case of malaria. So this delayed referral causes severe malaria. And then by the time they are referred to the larger hospital facilities, many has entered into coma, convulsions, cerebral damage, and the like. Self-medication and traditional remedies. I stated earlier that malaria is like a family member now. We live with them in our house. So many Sierra Leoneans know what to do when they contact malaria, even without visiting the hospital. So many times, many self-medicate. Whilst they are self-medicating, certain people either underdose or overdose. And this is a very strong challenge for us. The traditional remedies I mentioned earlier, there are certain roots and herbs, they don't have measurements. They just tell them, just take a cup. They don't tell them the right cup to take. So some will take a big cup, some will take a little cup, and this sometimes causes, fluid overload in children. So many children become intoxicated with those herbal drugs. And we have to sometimes, aspirate it out of them because many of them enter into unconsciousness because of these fluids. Climate conditions favored mosquito breeding. Like we stated earlier by my colleague, we have heavy downfall of rain. And because there is poor drainage system, there are so many stagnant waters. There are certain cups around that water settle in, and the mosquito breeds in them. They are causing multiplication of them and then reinfection. Dependence on international funding and support. Like I stated earlier, Sierra Leone is a developing nation. We may have the manpower, but we don't have the funds. So we depend on international funding for these projects. We can't afford this drug. So we are very grateful to all our partners for what they have done by bringing this here. In conclusion, malaria remains a major health challenge in Sierra Leone. We can't overemphasize that it is a major health challenge. Children and pregnant women are most affected, especially children under 5. Prevention and early treatment save lives. The vaccination offers new hope. Continued global support is essential because we need the funds to purchase these vaccines. We need to expand access to malaria vaccination. Strengthen surveillance and laboratory systems. Like someone mentioned when she was giving her own side of the presentation, there are times when the RDTs, the rapid diagnosis tests, are not available to conduct the malaria test. So we have to do clinical diagnosis. We have to diagnose clinically by what we see. And sometimes it might not be accurate because certain symptoms are not peculiar only to malaria. So we need to strengthen more lab, because if we have more laboratory, there is no way we can miss malaria diagnosis. So we need more laboratory systems to strengthen them. There is also improved community education and early diagnosis. Despite the fact that many Sierra Leoneans know what to do, how to prevent themselves from contacting malaria, we still need to go out and do more sensitization because people tend to forget. Increase investments in healthcare infrastructure. We need more infrastructures. We need more hospitals. We need more state-of-the-art hospitals that can cater for the likes of malaria. Malaria might not be common here, but to us, it is really life-threatening. Enhance local research and innovation. Our research needs to be top-notch in order to know what to do when it comes to malaria. Thank you very much for listening.
Okay, thank you very much. So, do you have any comment or question in the chat box? Okay, so there is some question and comments. Thank you, our dear friends from Sierra Leone. My name is Yuki, a former health delegate in Sierra Leone. I just want to say big thanks for your devoted work and care for patients and fighting against malaria. I hope you were having a wonderful time in Osaka. I learned a lot about the burden of malaria, especially how children under 5 years old are more vulnerable and how delayed treatment can lead to severe complications or even death. I would like to learn more about which complications are the most difficult to treat and how you achieve successful outcomes in patient care as well as preventive care. Thank you and hope to see you in Sierra Leone. So,
sorry. Hi, sorry.
So if somebody can explain a little bit about complications and there's a question. So if somebody can explain a little bit about the complication and also the most difficult to treat.
I think the cerebral malaria, the one that is whenever it's being half treated, but that's what I've said. If you have not finished your medication and then they have asked you to go and finish, you didn't, and then you come back, it's now being complicated. So you get what we call encephalopathy. So it has already gone to the brain, so you have a lot of convulsion. Sometimes you don't have even access to the medication, the phenobarbital or the the hospital will not have it, and then they have to write you to things. They go to the pharmacy, and then you start going from one point to another. All the people that have the patients, like the mothers or whatever, they say they don't have money to purchase this medication. So that is serious complication for us. It's difficult, like, to treat. So the cerebral malaria is the most difficult one, or the most complicated one that is difficult to treat. So preventive measures that we have said before. There are a lot of communication. We go to schools, we do health talks, we go to communities, and then of course now the government is trying with the help of partners. They have introduced the vaccination, although some people still have might in taking vaccines because they say, oh, they want to reduce our lifespan, they want to do this to our children. So you still need to educate them about it, but that is one of the preventive measures. Of course, the mosquito treated net, yes, some of them will collect it, but they will still not sleep under the mosquito treated net. But these are just few of it. And then the medication that we talked about, giving them like prophylaxis earlier before ever you have the malaria and disease. So these are the preventive measures, and the complication is cerebral malaria.
May I add?
Wait, I'm going to explain a little bit. So I cannot translate the one by one, but the summary. やっぱりノーマラリアがやっぱり一番、やっぱり、治療しにくい。で、途中でお薬をやめたりとかするので、軽症を持って帰ってくる。そこら辺がやっぱり一番難しい問題。で、予防っていうところにおいては、もちろん、ワクチンとか、それからモスキートネットとか、いろいろあるけど、配ってもやっぱり使わないとかっていう問題も多いし、ワクチネーションを打たないっていう問題も多いから、そこら辺をいかにコミュニティとかに行って、人に分かってもらうかっていうところがやっぱりすごく、やっぱり大事になってくるっていう感じだったかな。大体のサマリー的には。Yes, please add.
Yes, I wanted to add to the most difficult to treat in addition to what she has said. In working in the care, we have seen a lot of children coming with it, and these three are more common. That has led to several deaths, and these are hypoglycemia,
Yes.
convulsions, and severe anemia. Because these are the effects of the infestation of the malaria virus or the malaria infestation in the body. So when it enters the body, it eats off the glucose in the system, and the baby is already weak. He or she cannot take in fluid because he or she does not have appetite to eat. So the glucose keeps going down and down. So we have to keep treating the glucose while treating the malaria. And then there is the anemia side. It is attacking also the red blood cells. So you are also trying to treat the red blood cells, the severe anemia, while treating hypoglycemia and it's the malaria. And then the baby fever skyrocketing, that is increased fever. So you have to treat the fever plus the hypoglycemia and the severe anemia. So these three go together in complicated malaria. When you treat this three, you are able to handle this three, you are going to be able to control the malaria. But if you are able to treat any of these three, it is going to be a difficult ride for this particular case.
私たいって言ってたのは、これ質問しようと思ってたんですけど、多分ちょっと説明が足りなかったので、いわゆる低血糖と、それから貧血、それから、どこだっけ痙攣って言ってたけど、この痙攣、この3つなんですけど、何しかこの、アネミアもめちゃめちゃひどい、ヘモグロビンが3とか、4とかっていうのはもうザラに来るので、どれだけシビアかっていうアネミアのところが非常にシビアであるっていうことと、ハイポグライセーミアも低血糖で死ぬぐらい、もう真っ白なぐらい、低血糖になります。で、さっきご飯食べてなかったからとかっていうのを言ってましたけど、もちろんそれもあんねんけど、基本的には、さっきグラフのところで、5歳以下のところでめっちゃ山が上がってる。あれね、マラリア原虫の数なんですよ。マラリア原虫があんだけ多いね、5歳以下になると。で、マラリア原虫が、いわゆる、グルコースを消費するんですよ。糖分を。なので、多ければ多いほど血糖が低くなる。だから5歳以下の方が低血糖にすごくなりやすい。だから、すごい低血糖で来るんですよ。もう意識なくなって。で、あと、痙攣の問題。で、この3つだったよね。がある。で、それを、同時に、その治療をする。だから、マラリアの治療もしないといけない、痙攣の治療もしないといけない、ハイポグライセミアの治療もしないといけない、アネミアの治療もしないといけないっていう、これが、同時にやってくるので、非常にやっぱり治療が難しいっていうところが、あるのが、やっぱりすごく大きな問題だっていうふうに、今、彼女は言ってました。はい、Thank you so much.
I don't know why, but it's not still working now. So, but the growth of some species can show the comment.
Yes.
So, I will connect it.
And also, I'm going to explain a little bit one more thing about the convulsion. Convulsion is not only due to the fever, because the malaria parasite also break the red blood cell. So this blood cell is also blocked the blood cell. So it means the ischemia. This is one thing.
especially for the primary facility, because these are the hospitals that are in the community, which people go to more frequently than even coming to the tertiary hospital. Also working with partners, like I said, go to the northern, they also go to the community and then talk to them about malaria and yeah, it's like when parents see, oh, this is what it's called malaria, and then the government also have what they call the malaria control program. There is a whole program for it. So they have it
Nationwide, you mean?
nationwide, yes. So even because April 25 is World Malaria Day. So government went out to the community and they were sensitizing people. They distributed the malaria insecticide net. And then they also were having a station where they were encouraging people to come for the vaccination. Because like I said, there is still a might. People are afraid to take it. So these are all the plans that government put together. And then once in a while, going to the radio station, talking about malaria and then everything. So there are plans in which to follow so that it will prevent you, or you take a prophylaxis, or how to treat it, come to the facility. Sometimes, let me not say sometimes, most time it's free, just that we get this medication, like this other person said, the dismantling of UFN, so the product is not much. So you have to buy, they will do some for you, and then they ask you to go and buy some. So if you can afford it, yes, then if you can't, then it's a problem. But there are plans, these are the plans that the government has nationwide. Yeah.
So nationwide. So that, 全然覚えてない。長いのでなかなか覚えられないですけど、もちろん政府がそのコミュニティでのアクティビティっていうのはプランを持っていて、例えばさっき言ってた蚊帳ですね。防虫効果のある蚊帳であったり、バクシネーションであったり、あるいは予防薬、プロフィラキスの分とかっていうのをやったり、あるいはセンシタイゼーション、いわゆる啓蒙活動、プロモーションをやったりだとかして、やっぱりバクシネーションもやっぱりこう、なんていうの、迷信みたいなのがあって使わなかったりとかするから、そういうふうなことをちゃんと聞くんよっていうセンシタイゼーションしたりっていうのは、ちゃんとプランもあって、そういうふうにやる。だけど、やっぱり今さっき言ったみたいに、RDT のテストが手に入らへんとか、やっぱりそういう問題がやっぱり起こってきてるので、やっぱ政府としてのプランとかストラテジーはありますよということでした。
The last one. So last one. Oh,
これですかね。
これ the last one. No, other one.
Sorry, I forgot to introduce myself. I am Nobuhiro Kadoi, who used to work for MOHS in Sierra Leone in 2015 to 16. I have another question. What is the reason for the reduction in vaccination, third and fourth doses intake?
Yes.
Yes.
The availability of the drug.
Availability.
Like I stated in my report, the vaccine came, but it was not enough because of the large quantity, because of the number of people that needs it. So now they prioritize it according to who should get it. So in the community, there is not enough of the vaccine in the healthcare centers. So there is not enough of it. Secondly, ignorance. Yes, many will start taking the first and second dose and say, okay, I'm okay. I don't need a third and fourth dose. So they do not know the danger behind not taking the complete doses. So I can say ignorance. Another thing is just pure negligence. Some people are just negligent. They just think, as long as I'm not paying for it, I do not have to value it. So they don't take it seriously. Last is distance. Some people live in places where to get the vaccine is very far. So if I have to walk like 2 kilometers away, some people walk. And if they have to walk to go to the healthcare center for the first, second, by the time they are too tired, say the distance is too far, I can't go that way. So these are some of the reasons why
Accessibility to the health.
The third and fourth doses.
Regarding the vaccination, just like the top first.
Yeah.
So this, how about any side effects by taking vaccine? Because of the side effect, they may not really report that.
Well, so far we don't have, not as the reported.
For now, we have not recorded any side effects. Yes.
And they only give
The evaluation is still ongoing. So by the time, maybe in the next 3, 4, 5 years, maybe something would have come up and then we'll address it.
And then they are aware that they have to pay reports.
Yes, they tell them, because they will have the time for the next visit on their cards. Like if you take it today, they'll say come after 2-3 days, and they give you the date in which you should come. So they know when they should come in, but those factors sometimes limit their successfulness.
まあ、この3回目、4回目を打たないのはなんでっていうのは、まずは絶対量が少ない。全員に向き渡るだけない。それからもう一回は、1回、2回打つけど、まあ3回、4回目、まあいいか。で、もうこれ何言ってたかな。そう。やっぱりその、場所に行くまで、ワクチンを受ける場所に行くまでがやっぱりアクセスがやっぱり悪いので、そこにアクセスできない。もうこんなこと言ってましたよね。
無料やからそんなに。
無料やからそんなに聞かないんじゃないのみたいな。っていう、その、なんともはや、こう、ちょっとなんでですのっていう理由で、やっぱ打たない。この4つぐらいが理由じゃないかなというふうには言っておられました。すいません、音声が聞こえてません。聞こえるようになりました。すいません、今日はたびたび、音声が、切れてしまったんですけど、他なんか、フロアから質問ありますでしょうか？ I have a question, actually, because this is quite important, because you were talking about malnutrition. And I know this is very difficult to administer IV for the patients, but how we can deal with it? Because it's also impossible not to give IV line at all. But malnutrition, what kind of thing we have to be careful?
Well, most of them we put them on Resomal if they can tolerate, or even if they don't, we give them an injection tube and we feed them hourly based on their body weight. Well, for some of them, we have to put them on maintenance doses. So those maintenance doses are like half of what they should have if they were not having SAM. So if you are going to have, as a normal baby is going to have like 500 mils of maybe half strength, then the child with the SAM will have half of that. So they won't have fluid overload. So that is what we do at times. So Resomal is there for us.
栄養失調の方は、やっぱり点滴をたくさんすると、もうすぐバッとなって、心不全とかになったりとかするので、あげない。で、リソマルっていうのは、いわゆる、ORS あるじゃないですか。大塚とかの経口補水液。経口補水液の、栄養失調の交番っていうのがあるんですよ。で、ちょっと電解質のバランスが違うんですね。むくみにくいようになってて、それを経口的にあげるか、飲まれへん子は LP チューブを入れてでも、入れてする。で、それか、メンテナンスドーズって言って、普通のいわゆる、サムっていうのはシビアアキュートマルニュートリション。だから急性栄養失調じゃない子の半分の量を、いってメンテナンスするっていう形にするというふうに言っています。Thank you so much. Alright. Yes.
Very simple question. How many malaria cases do you have in the hospital? Doesn't affect numbers. I don't have kind of idea.
It's accounted for the higher, so we don't have, that's because it's still being evaluated, even the vaccine is still out there. So for now, we do not have the yearly.
More especially because the vaccine is high speed. Yeah.
So what I think was saying, so we don't like have the actual, but like if you're having like 10 cases coming to the facility, you have like 8 for malaria. So say the actual statistics would have so much. If we are seeing 10 cases per day, 8 will be positive for malaria. Yeah.
So it's very high. If we have a fixed, it like we have very experience and knowledge, according to the presentation, it was really informative. That's why I thought that you have so many malaria cases.
Yeah.
どれぐらい1日に来ますかって、どれぐらいのマラリアのかかりますかっていうのがなんですけど、ちゃんとしたデータはないけど、10人来たら8人来ますよっていうぐらいは来ますっていう。
And one more question. Yeah, it's not really simple.
It's okay.
Should be simple. Should be simple. Thank you. So you mentioned about the seasonal malaria chemo prevention,
Yeah.
right? So, you said that there's like eligible district. Not eligible.
No.
So you do that kind of campaign?
No, I didn't say eligible district. I said like it took us long to start that kind of thing, except like for Senegal and then the Gambia. So everyone is entitled to this chemo preventive as long as you go to the community or the community goes to you, because we want to prevent the disease before you already get it. Because before they go to the facility, it's already been severe. Because like she was presenting, she was talking about traditional medication and all. People don't want to go to the hospital because they think it's expensive, it's time consuming. So if we go to the community, we give them this preventive medication, or if they come to us, we give them. But like it took Sierra Leone a long time to start doing this chemo preventive medication therapy. Like giving them, yeah. So it's always there. So because throughout the year we have malaria, not like, oh, today malaria is here, this month, next month is not there. So all around we have malaria. So this medication are
一年中マラリアがあるので、シーズナルっていうふうに、この周りの国みたいにシーズナルっていうのは決められないので、やってるっていうのと、前からやってて、来たらあげる。で、コミュニティにそうプリベンティブであげるっていうふうにしてる。まあ、基本的にはそのシーズナルのこの山があんまりないっていうのがシーズナルの方法を取ってないらしいです。確かに。
And in addition,
still I think
so if I understand, that you conduct a kind of campaign out there, seasonal malaria chemo prevention, but it's not a campaign.
Yeah, it is, because before this time we are not doing it like at all. So if now the information is now there saying pregnant women is a must that you take Fansida after your first trimester. So everyone knows it, except for the hard to reach areas, because we have some areas in which they don't have a radio station, you don't have like way of reaching them except you go there, and then it's so difficult. You have to cross rivers and everything. But for the areas that we can reach, this information are out there that these things, preventive measures, that you need to go and take your medication, whether you are pregnant or under 5s. So these information are out there, is a must. Yeah, except if you don't want it, or it's not available. Maybe come to the facility and then we say it's finished.
So it means prophylaxis is quite common, but it's not seasonal.
It's not
seasonal.
Yeah.
It's like you have seasonal malaria. We have malaria in January,
It's the endemic.
or like other countries like the same
Endemic.
they have seasonal malaria.
Yeah,
For example, during malaria is high during the
Rainy season, but for us it's always high.
It's always there, not like that. It goes up. For the pregnant women, we protect them because we don't want this malaria to affect the unborn child, because it can cause the barrier between
The mother and
the child. We don't want that.
And when it does, and someone was talking about the complication, it goes directly to the brain, and you don't want this kind of complication. Yeah.
Thank you. Okay, this one is the last.
Yeah.
Sorry, I know, but you can ask that later. You can ask, but this is the last one.
My question will be the follow-up question, so is it okay?
Okay, no problem.
So according to your presentation, the under 5 years children is more vulnerable for the malaria due to the immune system. So my question is there any differences between us, because the Japanese has less opportunity to experience the malaria, so our immune system will be weaker.
Yes.
The people can get an immune system naturally without the vaccine.
Yeah,
So,
no.
you be like the other 5 children. I don't think we have any malaria. But mind you, Suzuki-san, yes, he's in Sierra Leone. He has been infected with malaria 3 times. So he now has immunity. He will have his distance.
So that we are safe for the children. Yes. This is true. Mama mentioned because the way she got the malaria, it's not like you, Sierra Leone people, because she must be admitted. But for adults, like a normal cold, I catch a cold, I catch a malaria. So the for us also there is no immune system, the I think antibody. So the probably is quite severe, like baby.
Yes, please.
Yes.
Finally, Sierra Leone is surrounded partially by water, and because of that, that is one of the reasons it's not similar. There's always a body of water around it, so there's always a breathing space for malaria. So, like she said, you can only build antibody for a disease if you have it. So, if you want to have an antibody of malaria, you have to catch the disease.
まあ、もしね、マラリアのちゃんと抗体をつけたいんだったら、病気になると思うから。そういただきました。Thank you very much. Thank you very much. So the class 皆さんありがとうございました。ちょっと時間が押してしまいましたが、ちょっと早口で分かりにくかったところもあるかもしれませんが、YouTube で再放送してますんで、また見ていただけたらなというふうに思います。ちょっとキャプションをね、希望されてたんですけど、キャプションはストラマに入れないとちょっとつけられないので、申し訳ないです。ちょっとキャプションがつけられなかったので、本日は英語で活かしていただきました。ちょっと9月の、勉強会テーマがちょっと決まってないので、ちょっと今アナウンスできないんですけれども、またFacebook 等でアナウンスしたいと思います。本日はどうもすいません、9月の間違い、9月ではなかったです。8月の間違いでした。8月をちょっと言えないんですけど、またアナウンスしたいと思います。そう、だって5月って言ったら8月っていうか。の分はまだ決まってない。8月は、
今ケニアにいらっしゃって、その方に、キャリアの、これまでのキャリアっていう、事業を続いていることで、8月の代表のに、はい、お話ししてもらいます。
はい、私が8月と9月を間違えたからダメだったんですね。次回は9月って言ったからダメだったんです。すみません、9月はまだ決まってません。8月は、またアナウンスします。はい。ありがとうございました。Thank you so much. Thank you. Thank you. Thank you. Very good. Very good. Yeah.